Good evening, everyone. Are my slides visible?
Yes,
Yes,
yes.
sir.
Yeah.
Yes, sir.
Yeah. Good evening, everyone. Thank you, Kumar sir and team for giving this opportunity. So today my topic is neuroendocrine tumors in the lung. To begin with, NET, these are the heterogeneous malignancies originating in amine precursor uptake and decarboxylation, acute neuroendocrine cells. So this first description was like a slow-growing tumor, cancer-like tumors by Siegfried. These NETs are typical carcinoid or typical carcinoid, large cell neuroendocrine carcinoma, and small cell lung carcinoma. These are characterized by, these are the features. So typical carcinoid is morphologically carcinoid cells. Mitosis rate less than 2 with no necrosis. A typical carcinoid will have a neuroendocrine morphology with mitosis rate of 2 to 10 per 10 HPF with a punctate necrosis, while large cell and small cell neuroendocrine carcinoma, these are high grade with more organized neuroendocrine morphology with high Ki-67 index and extensive necrosis. Chromogranin A and synaptophysin assays may be helpful in diagnosing large cell and small cell neuroendocrine carcinoma. So first step is to separate non-small cell versus neuroendocrine neoplasms. Lung neuroendocrine neoplasms constitute about 35% of the all lung malignancies. This is the WHO classification for lung neuroendocrine neoplasms. First entity is diffuse intestinal pulmonary neuroendocrine cell hyperplasia. Second is well-differentiated lung NET. These are either typical lung NET or atypical lung NET. Others are lung neuroendocrine carcinomas, which are divided into large cell NEC with morphological features of well-differentiated NET. Other is large cell NEC, small cell lung cancer, and combined features of NEC and NSCLC. So mitosis and necrosis are necessary for classification. This is the pathologist proposal to incorporate Ki-67 and mitotic count and necrosis in the grading. So grade 1 tumors are classified as with mitotic count less than 2, with Ki-67 less than 4, and with no necrosis. So in this study, all typical carcinoids were reclassified as grade 1, and atypical carcinoids 29 were grade 1, 45 were grade 2, and 1 was grade 3. This is again pathological classification, well differentiated, either low or intermediate grade. They are typical or atypical carcinoid, and poorly differentiated are large cell and small cell lung carcinoma. Almost 91% of the NENs are high grade, with 9% are low grade carcinomas. This is epidemiology. If we see of the all lung cancers, a typical carcinoid constitute only 0.2%, while typical carcinoids constitute 2% of the all tumors, while small cell and large cell constitute about 23% of the all tumors. Among the neuroendocrine tumors, lung carcinoids are almost 25% are lung carcinoid, remaining are gastroenteropancreatic NETs. What can be the clinical features? 10% of the patient may present with carcinoid syndrome characterized by the systemic release of vasoactive amines. Other is ectopic ACTH and acromegaly. This is the survival outcomes of carcinoids. If we see a typical carcinoid and typical carcinoid, they have a prolonged survival compared to large cell and small cell lung cancer. Moving to the molecular biology, main one alterations, these are almost exclusive to carcinoid, whereas TP53 and RB1 regulatory genes and PI3K are AKT-mTOR pathways were significantly enriched in carcinomas. RB1 and TERT had impacted on survival regardless of the subtype. KMT2D was prognostically relevant for small cell and main one for atypical carcinoid. Moving to the staging and characteristic for lung NEN, which is well differentiated with very low Ki-67 or low grade typical carcinoid. Morphological imaging, we can do a total body CT scan, or functional imaging, we can do gallium-68 PET-CT DOTA peptide scan. Circulating marker is chromogranin A. Moderately differentiated or intermediate grade Ki-67 3 to 20, a typical carcinoid. For morphological imaging, we can do a whole body CT scan, and for functional imaging, we can do gallium PET CT dotapeptide plus FDG PET CT. Circulating markers are chromoganin A and non-specific enolase. For poorly differentiated carcinomas, that is large cell and small cell carcinoma, FDG PET CT can be done for functional imaging, and circulating marker is non-specific enolase. Moving ahead to the management of lung NET, for all resectable or locally advanced disease, treatment is complete anatomical resection. Either it can be segmentectomy, lobectomy, or pneumonectomy, along with adequate lymphadenectomy that includes a minimum of 6 nodes or stations, 3 of which should be mediastinal, including the subcarinal station. Moving to the adjuvant therapy, so radically resected lung NETs, as of now, there is no role of adjuvant therapy. For loco-regionally advanced or metastatic NEP of GI, lung, and thymus, there is no known role for systemic treatment in adjuvant setting. There are some studies showing benefit of adjuvant chemo plus minus RT in selected cases. So if you see for bronchopulmonary NET, in a localized disease after lobectomy or anatomical resection plus nodal sampling, observation is strategy. For locoregional or resectable locally advanced disease stage 3A, anatomical resection plus mediastinal node dissection. If it's a low-grade typical carcinoid, we can consider observation. For intermediate grade atypical carcinoid, observation, or there is a probable role of systemic therapy plus minus RT only after discussion in a multidisciplinary tumor board. So this is a paper which shows that there is no consensus on adjuvant therapy. Only patients with atypical carcinoid, that is intermediate grade NEC with positive lymph node, especially if there is a high proliferative index, should be considered for adjuvant therapy and discussed on individual basis in the context of multidisciplinary tumor board meeting. So there is no routine adjuvant therapy recommended according to ESMO. It can be considered in selected patients with high risk of relapse, that is end to disease after multidisciplinary tumor board decision. If we see the management, anatomic resection, typical carcinoid, we consider observation. For a typical carcinoid, if it is N0, N1, we consider observation. For N2 and a special population, maybe with high proliferative index, we consider systemic therapy plus minus RT. Moving ahead to the advanced disease, advanced neuroendocrine tumors, options of systemic therapy. So these are the treatment options for advanced well-differentiated lung NETs, that is octreotide or lanreotide, that is somatostatin analog, everolimus, chemotherapy, peptide receptor radionucleotide therapy, or liver-directed therapies. Moving ahead to the first line therapy, for tumors which are functioning or SSTR functional expression is there on scan, with low tumor grade or slowly progressive disease, somatostatin analogs are used as a first line treatment. For a non-functioning tumor and intermediate tumor grade, as well as unhomogeneous SSTR expression and rapidly progressing disease, everolimus is the drug which is used. It's a mTOR inhibitor. If we look at the ESMO guideline and NCCN guideline, for slowly progressive disease, either observation or somatostatin analogs are recommended. For atypical carcinoid with a significantly progressive carcinoid or post-SSA therapy, everolimus or chemotherapy, that is temozolomide based chemotherapy. On progression, we may consider PRRT, interferon alpha, or platinum based chemotherapy. If we see at NCCN guidelines, it also for a distant metastatic disease in bronchopulmonary or thymus NET, for asymptomatic or low tumor burden, either we consider observation or octreotide or lanreotide if there is a SSTR expression. In patients who have a clinical significant tumor burden and low grade typical carcinoid or with evidence of disease progression, clinical trial is the preferred option, or observation for selected patient. If there is a SSTR expression, octreotide LAR can be used, or everolimus is other option for bronchopulmonary NET. Other options are PRRT cis-itopo-based chemotherapy or temozolomide capecitabine therapy. And if there is a liver predominant disease, then we can consider liver directed therapy. Same for disease with some multiple lung nodules or tumorless and evidence of diffuse pulmonary neuroendocrine cell hyperplasia, observation or octreotide remains the treatment choice. Moving ahead to the trials for everolimus. So these Radiant 3, Radiant 2, and Radiant 4, these are the phase 3 trials for everolimus. And Ramsay, Luna, these are the phase 2 trial for evaluating role of everolimus in lung NAT. So in Ramsay trial, they evaluated everolimus with placebo for a non-functioning lung subgroup. In Radiant 4, everolimus was compared with placebo in non-functioning lung NATs. In Luna trial, there were 3 arms, pasireotide versus everolimus versus combination of pasireotide plus everolimus, and this was evaluated for functioning as well as non-functioning NAT involving 121 patients. Moving to the Radiant 4 study design, in this study, patients with well-differentiated, advanced, progressive, non-functional NAT of the lung or GI origin were included, with the absence of any active or history of carcinoma syndrome, pathologically confirmed disease, or enrolled within the 6 months of radiological progression. They were randomized to everolimus 10 milligram per day versus placebo. Endpoints were PFS, and key secondary endpoint was OS. They were stratified either by prior somatostatin drug treatment or tumor origin or performance status 0 versus 1. So in this study, there were 90 patients with a lung NAT, and if we see the PFS treatment effect of everolimus, with everolimus, median PFS was 9.2 months compared to the placebo, with which it was 3.6 months, and hazard was 0.5. Also, the subgroup analysis of Radiant 4 trial, it does favor in lung NAT, it does favor everolimus. This trial has low grade 26 patients and intermediate grade 37 patients, and 56 patients has received prior antineoplastic therapy. Luna trial, this was a 3-arm randomized phase 2 trial. In one arm, primary endpoint was progression-free rate at 9 months. The 3 arms were long-acting pasireotide 60 milligram per month IM, everolimus, or combination of long-acting pasireotide plus everolimus. The most common treatment-related adverse events were with the combination arm, hyperglycemia, diarrhea, and decrease in weight. With the everolimus arm, it was stomatitis, diarrhea, and decrease in the weight. And with pasireotide, it was hyperglycemia and decrease in weight. So efficacy-wise, with everolimus, the median PFS was 12.5 months. With pasireotide and everolimus, it was 12 months. And with only pasireotide, it was 8.5 months. In Radiant 4 trial, it was 9.2 months PFS with the everolimus. So 9-month PFS was 70% in Radiant 4. So moving ahead to the next, chemotherapy in the advanced lung NAT. There are 2 treatment options. One is temozolomide based chemotherapy or oxaliplatin based chemotherapy. When tried with platinum, either cis or carboplatin, most of the pulmonary carcinoid, they do not respond to platinums. These are the phase 2 trials of cisplatin or combination of cis-etoposide in well-differentiated or NAT grade 3. The response rate were in between 7 to 20%, and they do not show a good response to platinum. These are the trials of temozolomide in thoracic neuroendocrine tumors. So with use of temozolomide and capecitabine, there was a benefit in PFS. Few trials were retrospective and few were prospective trials. In this trial of Krona J et al., where temozolomide capecitabine was used in thymic NATs. So there was a 70% response as a stable disease, and time to progression was 20 months. Across various trials of temozolomide, there was a benefit in PFS. These are the trials of oxaliplatin-based treatment in advanced lung NAT. Walter T. et al. They use oxaliplatin-based trial, oxaliplatin-based chemotherapy in 45% patients, where the PFS was 15 months. These are other trials where they have used CAPOX, where the PFS was 20 months. In other retrospective study by SPARA, PFS of 8 months was seen was oxaliplatin, and with oxaliplatin and bevacizumab, PFS of 19 months was seen in phase 2 trial. Moving ahead to the PRRT in thoracic NAT, these are the different studies which involve more than 10% of the patient. If we see there was a response rate of 28.6% with the PRRT of Atrium 90. These are the different trials with different nuclear molecules. I think this will be discussed in detail in the next lecture. Moving ahead to the liver-directed therapies. So in patients with the liver predominant disease, we can use liver-directed therapy. So if it's a oligometastatic liver disease, with lesion less than 3 metastases or less than 5 in selected cases, measuring less than 3 centimeters, percutaneous ablation can be used. For multifocal symptomatic or progressive disease under systemic treatment, transarterial embolization, transarterial chemoembolization, or radioembolization, these are the liver-directed treatment options. These are some trials of immunotherapy in neuroendocrine tumor, which evaluated pembrolizumab, spartalizumab, and toripalimab. Response rate with immunotherapy are not so great in NAT, which varies between almost 6 to 40%. So yet we don't have any immunotherapy data in NATs. Moving ahead to the next part of neuroendocrine tumor, it is small cell lung cancer. I think it has been discussed by Dr. Monica ma'am in details. So I will go through in pathological diagnosis is made by WHO classification. ISC panels that can be used are synaptophysin, chromoganin, CD56, TTF1, Ki67 for grading, keratin, and EMA. Markers of neuroendocrine differentiation are seen in 75% of the small cell lung cases. This can develop from histological transformation, which is seen in 5 to 14% of the patients. There are no molecular markers that are recommended for treatment selection. Markers reflecting neuroendocrine differentiation, that is synaptophysin, chromoganin, and CD56, neuron-specific enolase, dopa decarboxylase, GRP, and IGF-1. These are the other molecules, other markers. This small cell lung cancer, this can also produce several polypeptide hormone leading to excessive STTH or vasopressin syndrome. Treatment over the period of last 30 years, treatment have been evolved, but standard regimen remains platinum plus etoposide or irinotecan. Recently, we have a data of immunotherapy in non-small cell lung cancer. In platinum, mainstay is cisplatin for young fit patients, carboplatin for older patients or with comorbidities, or irinotecan platinum is other alternative to etoposide platinum. And these are durvalumab and atezolizumab. These are the newer immune checkpoint inhibitors. So the first line options, we have combination of durvalumab plus platinum etoposide or atez plus platinum etoposide, or only platinum doublet chemotherapy, PCI and radiotherapy at physician's discretion. If it is a sensitive disease to first line, we can re-challenge platinum chemotherapy at further progression. If it's a refractory disease, second line options are limited, that is topotecan and lurbinectedin. Empower 133, this is the trial of atez plus chemotherapy in small cell lung cancer. Caspian trial, this is also discussed by Dr. Monica. Moving ahead to these are the various trials of immunotherapy in small cell lung cancer. In Empower 133, we have a median OS of 12.3 with atez and chemo combination. In Caspian, it is 13 months, and in Keynote 64, it is 10.8 months. while 12-month OS rate are 51.7, 52.8, and 45.1%. So this is a trial of lurbinectedin as a second-line treatment for patients with small cell lung cancer. This is a single-arm, open-label phase 2 basket trial. So, due to paucity of treatment option after first line, lurbinectedin was evaluated in phase 2 study for patients of small cell lung cancer after failure of platinum-based chemotherapy. It's a selective inhibitor of oncogenic transcription. This study included 105 patients at median follow-up of 17.1 months. Overall response was seen in 37 patients, that is 35%. Most common adverse effects were hematological abnormality, anemia, neutropenia, thrombocytopenia. 10% patients had serious adverse event, and febrile neutropenia was seen in 5% patients. So this has shown efficacy as a second-line treatment option. To summarize, lung NAT, this should be managed within or in collaboration with a dedicated multidisciplinary team. A complete or radical anatomic resection plus N1, N2 lymphadenectomy is the treatment for resectable lung NATs. Everolimus is only approved drug for advanced lung NAT. Octreotide or lanreotide, they were not specifically approved, but they are recommended for indolent and functioning NATs. Chemotherapy, PRRT, liver-directed therapies, these are other options in advanced NAT.